Hi, all. Welcome to Socrates Medicine. Let's score some high yield ethics, questions, concerns, and let's get after it. Let's crush these boards. All right, so let's start off with the basics of autonomy. This is the patient's right to determine his or her own healthcare decisions. Now, autonomy trumps beneficence in almost every single case of medicine, and we'll go over the exceptions because, right, in medicine there's always exceptions. So let's get into it. If you have a patient, and these are all theoretical scenarios, right? Your patient presents to the ER with appropriate capacity. He has classic heart attack symptoms and he refuses an EKG or aspirin. He has the right to make the wrong decision. He has the autonomy to choose. And of course, in this case, refusing the EKG would be wrong, but he actually has the autonomy, the patient's right to determine his or her own healthcare decisions. Patients have the right to make the wrong decision. And this is in stark contrast to how we're trained, right? So even though we are trained to do what's in the best interest of our patients, the patient's right to act against his or her own best interest comes first. Patients ultimately have the right to choose the wrong treatment. Now, there are exceptions to this, and this includes patients that are doing something potentially dangerous to harm others. So what all does that entail? That's things like a patient that's planning on a mass shooting, or things like HIV, tuberculosis, or other STDs, right? This is when physicians can breach that confidentiality because we need to address this. It's not disclosing an HIV status. That's concerning for the patient if they don't disclose this to their partner, right? That could harm the partner. So we're able to step in, and this is an exception to when beneficence actually overrides autonomy. Competence versus capacity. So competence is determined in the court. O and an O. Competence, court, right? So capacity is something that physicians can determine. That's what physicians do. So capacity is the patient. It is basically the idea that the patient is of sound, appropriate mind. He or she is able to make his or her own medical decisions. And it's important to rule out other pathologies that can compromise the ability of a patient to have appropriate capacity. So things to look out for is, causes like on this list, for example. But this is not a comprehensive and exhaustive list. There are other things that we need to think about. Maybe that's causing delirium, things like a urinary tract infection, and aberrant thyroid function. So you want to consider doing a thorough neurological exam to test things like judgment, comprehension, memory, okay? Now, the boards and your schools are going to ask you maybe, oh, is this an option to consult psychiatry? Well, in this case, right, any physician has the ability to discern whether or not a patient has capacity. You don't need a psych consult every time you're trying to determine if a patient has capacity, okay? All right, so pediatric competence and capacity. So, these patients are younger than 18 years old, pediatric population. They are not competent to make their own decisions. So the question becomes, who can make their decisions for them? And the answer in this case on your boards or your in-house exams would be their parent or legal guardian can make the decision for the pediatric patient. Aunt Susie, neighbor Bob, they cannot make medical decisions for the minor. And just like all things in medicine, there are exceptions to this. So, if a child shows up in your ER and you're thinking you're going to need to intubate the child quickly and cannot find a legal guardian to do so, you go ahead and intubate the child. And so in emergency situations, go ahead and act in good faith and intubate the child. Now, there are exceptions to children who can make their own decisions. So we talked about the emergency cases. Likewise, partial emancipation of pediatric population includes STD, HIVs, prenatal care. So if the patient themselves is pregnant, right? Birth control and substance abuse. That's very, very straightforward, right? And then those patients, those pediatric population patients who are emancipated, so they're 16 and they're married, or they're 17 and they're independent, filing their own taxes, or they're in the military, or they themselves are a parent, right? They have a kid themselves. So just again, alternatively, a competent adult cannot refuse life-saving treatment based on religious practices. And this will be a classic board question in-house exam. Is you're presented with a Jehovah's Witness patient. She brings her child in, and the child needs life-saving treatment and needs a blood transfusion. This mother, even though her religious beliefs, she does not want the blood transfusion. You cannot withhold life-saving transfusion or life-saving treatment in this case because it would be considered child abuse. So the correct answer choice in that case would be, even though the mother disagrees with the physician to transfuse the child, because it's a life-saving treatment, go ahead and transfuse the patient. Additionally, a parent cannot refuse therapy for a child if they are developmentally challenged or have brain damage. So take a cerebral palsy patient, for example, who has a bowel obstruction with the mentation of a 3-year-old. Regardless of whether or not this child will become the next Dr. Fauci or pass away earlier than the average life expectancy, the parents cannot refuse the surgery just because the child has less mental or functional capacity. The only exception to the parents is when they are allowed to refuse care for their child, is when the child is so sick or deformed that death is inescapable. Okay, I don't think this is going to show up on your boards or in-house exams, but just to cover our basis, we'll review that, okay? So let's dive into psychiatric competency and capacity. I think these are pretty straightforward as well. So, a patient who is actively suicidal is deemed as lacking capacity, and they have impaired judgment. And you can understand that, right? They have impaired judgment. They can't make decisions for themselves appropriately. Okay? And likewise, adults with mental disabilities, this really includes any patient in a group home or patient with schizophrenia, for example. And if they're still able to retain the mental ability of depending on the source and literature that you read, mental ability between an 8 to 10-year-old, these patients actually have the ability to understand medical procedures and ultimately the autonomy of these patients. So they have autonomy enough that he or she has the right to consent or refuse medical therapy, even though they're an adult with a mental disability. That's pretty much it on this topic. The only other thing I may mention is they may try to trick you on your exams by saying, this patient is coming in with a known gambling addiction. Does he have appropriate capacity? Well, even though he's got a gambling addiction, does he or she have the appropriate ability to make financial decisions? Well, probably not, because they have a gambling addiction, but they are still able to make appropriate healthcare decisions. So just because maybe one aspect, like financial decisions, is hindered, they still have the capacity to make medical decisions. Okay, so don't get tricked or stumped or tricked on that type of question. Okay, that same patient is still considered to have capacity to refuse or accept treatment. Okay, and again, let's review that physicians are the ones that determine capacity. Informed consent. So we're getting into some pretty high yield stuff here. So physicians, The physician's duty to describe all treatment options, the risks and benefits of those treatments or lack of treatments prior to starting a treatment or procedure is informed consent. Okay? So I'm going to give you a theoretical scenario here. So when you have a patient, she has acute myelocytic leukemia, which remember, that's that M3 variant of AML, and you inform her about the risks and benefits of chemotherapy. Her condition deteriorates, and her husband wants to sue you because he read that all trans retinoic acid could have treated her cancer and that she was never offered this treatment. So remember that acute promyelocytic leukemia from your level 1, step 1, can be treated with all trans retinoic acid. So in this theoretical scenario, because you never informed her of all of her options, benefits, and risks to the treatment or lack of treatment prior to starting her treatment, you actually would be liable. And this, your treatment probably would not be held up in court. So again, we want to describe all treatment options, the risks and benefits of those treatments or lack of treatments before starting treatment or procedure. All right, so in terms of procedures, you really need to garner informed consent for each procedure that you perform, okay? It's pretty straightforward there. I could totally see this being a question as well, so I'm just going to give you another scenario. Let's say you're a M3 or an M4 and you're in surgery, and the surgeon, she's an excellent surgeon, and you guys are doing a laparoscopic appendectomy. So you're taking out the appendix, and you have this female patient, and so far procedure's going really well, and just towards the end of the procedure, you want to, look down, make sure there's no pelvic abscess formation, and you notice that there's a mass, a suspicious looking mass on the right ovary, right? So now you're concerned that, this is probably malignancy. The question is, what do you do? Should she go in and biopsy the mass? What should she do? And this, I could totally see this being questioned. The answer would be she should not biopsy the mass. She should not even do anything with the mass, right? While she's in the surgery in the OR, because you've only garnered or gained consent for this patient for this one procedure, which was removing the appendix, not removing additional masses. So make sure you get consent for each procedure that you do. Okay, very good. Now, last known wishes, that's pretty straightforward, right? If the patient, he or she would want to states they want to be intubated and understands all the risks and benefits with that, and suddenly becomes unresponsive in a question stem, go ahead and go with his or her last known wishes, and you can intubate the patient. Again, we touched on this pretty much. Consent is implied in emergency situations. The only caveat would be terminally ill patients with a DNR order. You can garner consent over the telephone. That's okay. And the pregnant women, this is a nice patient population to target ethics questions with. And so let's run through a couple scenarios, and that way you feel confident with it. So basically, pregnant women, they can refuse treatment. So let's say you have a 27-weeker, pregnant patient. She's 27 weeks along, and she all of a sudden requires a life-saving transfusion, and she does not want the transfusion. She can absolutely refuse. Now, if she delivered a premature child at 27 weeks, right, so right on the cusp there, she delivers a very, a preemie very, very early, and this baby now requires a life-saving transfusion, and she's very adamant she does not want the child to receive this transfusion. This would be a case, again, you go ahead, it's an emergency situation, and you do the life-saving treatment for the child, for the baby, for the premature 27 weeks early baby, okay? All right, that's pretty much it on this. So let's move forward. We talked about the laparoscopic appendectomy. Now let's get into some high yield informed consent stuff. Okay, so I'm going to present a scenario for you, and this will be very, very high yield. So, the person performing a procedure must obtain consent. So let's say you're an intern. The mid-level from a consult service asks you to obtain consent from a patient so she can place a central line via the subclavian axis. So my question would be to you is, what would you do? And you can pause the video and kind of think through it yourself. Otherwise, we can get back into the rationale. So this is a very tricky situation, right? On a couple different levels. You cannot put yourself into a situation to explain the risks of procedures that you did not decide if the patient, this is a very vague, and I purposely left this a vague situation, right? The hospital's busy and the mid-level consulting wants you to do this for them and yada, 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 right? And you've got pages going off and, all these other orders and things to do, right? So if this patient develops a pneumothorax and you don't know why the internal jugular vein approach was not being used, because, right, in this case, she's going to place a central line via subclavian. If you can't justify or explain why this is the case, and you cannot adequately inform the patient, right? And if an adverse event like this were to occur and the patient would develop a pneumothorax, which is a complication, theoretically that could occur, right, in this scenario, you simply stating, oh, well, the mid-level told me to do this, or, oh, I was just getting the paper signed for the patient, or, oh, I didn't know why or what was happening, that does not hold up in court, right? So you need to remember that this is your medical license on the line, and the person performing the procedure must obtain the consent, okay? Now, maybe an appropriate response that you would do, or how you could handle the situation, right, is just gently or delicately communicate to the mid-level that she herself must obtain consent. And this is just a side note, right, is just because the landscape of medicine is continuing to change, and probably will change 1 year, 2 year, 3 months from this video, right? Take care of yourself, right? Understand what's going on, inform yourself, check the ACGME website for your specialty to determine if you have to train under mid-levels, what percentage of the time, in what circumstances, and what, all of these things. Educate yourself accordingly with these resources through the ACGME. So bottom line, person performing the procedure must obtain the consent. All right. All right, so the end-of-life decisions, this is very straightforward. So if a patient no longer wants to continue dialysis for renal failure, and he has the capacity to make that decision for himself, that medical decision, then he can discontinue dialysis. It's very straightforward. There may be a question kind of guiding you that he seems down, depressed, and hopeless, and last 2 weeks he has, little interest and pleasure in doing previously things that he used to find enjoy, that were enjoyable, or that brought him joy previously. So they may hint here and there that this setting you up, that this patient has symptoms of depression, he is depressed. And if that were the case, then you would go ahead, and this would be a case you would consult psychiatry, or if you see the option of starting him on appropriate pharmacological management, like an SSRI, for example, then that would be fine. Okay? Very straightforward here. All right, so the advanced directive. This is basically an extension of the patient's autonomy. So what exactly do I mean by that? I mean that the advanced directive is what the patient wishes when he is unable to make his own decisions for himself. We kind of have two pathways that we can go about this, and we'll touch about living will, which is usually the wrong answer on your exam questions. And I'm going to explain why. And so basically, living wills are a document, right, that's very vague. And unless they specifically state things such as, I would like total parental nutrition in instances X, Y, and Z, right? That's very straightforward, and it tells you when you want TPN and when you don't. Now, these are helpful when they specifically state what the patient wishes for his medical care. However, oftentimes these living wills are very vague and include statements such as no heroic measures. Well, what exactly does that mean, right? Heroic measures to you means something completely different to me, right? Because, if you talk to a patient about it, they may state something like, oh, well, I don't want tubes in my throat or this or that. Well, oftentimes, right, tubes down the throat is a standard of care that we deliver in the hospital, right? So this gets dicey really quickly, and it's just tough to really interpret. So the takeaway of this is it's not that reliable. So let's switch over to the other arm of the advanced directive, which is the healthcare proxy. And you can equate this essentially as the durable power of attorney, or you may hear it as the medical power of attorney. And right, the durable meaning the patient wishes to extend beyond the duration of whether or not he or she has capacity. So ultimately, the healthcare proxy makes decisions on two requirements. So what are those two requirements? Well, the first one is it must be the patient's direct wishes, and it has to be what the patient would have wanted if he had capacity. So the healthcare proxy you can kind of think of in your head as a messenger. So what happens, right, if the patient does not have capacity and no advanced directive set up? So the next best step would be to speak to family to figure out what the patient would have wanted in this situation, right? So I'm going to give you a scenario. Let's say you have a 65-year-old female. She comes in, dyspnea, nuchal rigidity, altered mental status. Her husband's with her. Her healthcare proxy is her son-in-law, and you know that, okay, this is setting me up. I know that this is meningitis. I need a lumbar puncture, right? And so the husband is very adamant that he does not want a lumbar puncture done for his wife. She doesn't have capacity to make appropriate decisions. However, the son-in-law says, no, this is something that she would have wanted if she had the capacity. So in that case, what do you do, right? Does it matter that her son-in-law has the healthcare proxy? Should you listen to the husband? Well, in this case, right, the healthcare proxy is a messenger. He's stating what she would have wanted if she had capacity, right? So it doesn't matter if the husband doesn't want the lumbar puncture for her, right? That's not articulating what she, the patient, would have wanted. And besides, that healthcare proxy trumps all other family members or not, non-family members, friends, whomever is there trying to influence or direct care, right? So the healthcare proxy, the son-in-law, he states to you, yes, this is something she would have wanted a lumbar puncture in this event. Go ahead and go through. Then you would go ahead and go through the lumbar puncture due to the healthcare proxy being an extension of what the patient's initial wishes would have been. Okay. All right. Awesome. So that takes us up here to the do not resuscitate, or the DNR. Now, DNR order is very straightforward as well, and you're going to see a lot of these as you move forward in your medical career, right? So this is the idea that a do not resuscitate order is if the patient dies, and we're stating that, dying in this case is undergoing cardiopulmonary arrest. The physician does not attempt chest compressions, electrical defibrillation, or cardioversion, depending on the rhythm, right? Nor acute antiarrhythmic medications. Okay, so, and this is very important to understand. Okay, is patients with DNR orders, they are given the standard of care, right? They come in for pneumonia, go ahead and give them a Z-Pak. Depending on the criteria, right? If they can stay in the hospital, or if they need to stay in the hospital, or if they can go home, right? That gets, that's a different lecture, right? So they get standard medical care until they undergo cardiopulmonary arrest. And at that point, the physician takes that as the last or finite point of treatment or therapy for that patient, okay? That's something very important to understand. That's it. There's nothing more the physician will do with a DNR order once that patient has undergone cardiopulmonary arrest. The death of the patient, the death of the patient is loss of pulse, hypotension, and the inability to breathe, right? So one example I can think of, this is again theoretical patient, right? Is you're in the ICU and you're managing a patient for acute pancreatitis, and she has a Ranson criteria of 4, right? And that's a predicted mortality of 40%. It's pretty high, right? So even though she has a DNR, she can still be treated and managed in the ICU. The DNR order is independent, unrelated to her acute pancreatitis. Okay? So let's get into a question. And I just want to remind you, a good test-taking strategy would be, we're going to address the question at the very end of the question stem. So what is the most appropriate management of this patient? Or in other words, summarizing, what's the next best step? And you'll see this step 2, level 2. But stay, if you're step 1, level 1, this would be good for you as well to go through. If you want, I'm going to read the question, go through the answer choices. If you want, pause the video, think of what you think would be the answer, and we'll discuss accordingly, okay? So you have a 72-year-old male patient with terminal lung cancer on your hospital service, and he has now developed renal failure. He is alert and has elected to place a do not resuscitate DNR order in place at his own discretion. He is alert and oriented to person, place, and time. His potassium level is now elevated at 9 milliequivalents per liter. His wife is with him at bedside. What is the most appropriate management of this patient? A. Start Lokelma until the DNR status is discussed with his wife. I think that's a great thought, right? Lokelma is an excellent medication. It's faster acting than some others, and it can help drive that potassium level ultimately down, right? I think that's a good idea for medical management, but it's not the best option here for us. And that's because the second part of this answer is until the DNR status is discussed with his wife, right? He had appropriate capacity to place his own DNR, and he's oriented to person, place, and time. So his DNR status is independent. It has nothing to do with this high potassium. Now, if he undergoes an arrhythmia with this elevated potassium, which you should be thinking, okay, yep, I need to give him a stabilizing medication for his EKG changes. Absolutely, you're doing great. That's the right path. However, that has nothing to do right now. His DNR status does not have anything to do with his current issue at hand. So that's not the right answer. Now let's look at B. Undergo dialysis as the DNR does not affect his renal failure status. Yeah, I think that sounds pretty good. Let's hold on to that one and let's look at C. Undergo dialysis if the DNR is reversed. Again, him undergoing dialysis is independent of the DNR. He still needs medical management at this time. So this is the wrong answer. D. Do not proceed with dialysis due to his DNR status. Again, just because he's DNR doesn't mean he is shortchanged some sort of medical care, right? That has nothing to do with his acute renal failure at this time. So D is incorrect. And E. Administer PHQ-9 with TSH levels. Okay, this is a good thought. If you're considering, maybe he doesn't have appropriate capacity, something is interfering with his ability to make his own medical decisions. Maybe he's depressed. Give a PHQ-9. Okay, check his thyroid levels. That's fine for capacity, but he's oriented to person, place, and time. So this is not the best answer. So your answer is B. Undergo dialysis as the DNR does not affect his renal failure status. So that's it for this session. Best of luck to all of you studying boards. Reach out if you need anything. And nice job. Happy studying.